I guess.
Thank you, Nancy. Welcome to our Race to Erase MS Forum. I am Claudia Curry-Hill, and I've lived with primary progressive MS for over 35 years. 31 years ago, I met Nancy and learned of her vision of the Center Without Walls. The Center Without Walls program is funded by the Race to Erase MS and has provided support that has permitted the medical community to link together multidisciplinary scientific programs and expertise across the country to advance the understanding and the cause of MS and to develop new treatments. The center is a breakthrough success because of the vision, insight, and flexibility of these extraordinary doctors. I would like to introduce you to our Center Without Walls program panelists. Dr. Liliana Amascua, USC. Mark Barandis is our guest panelist. Dr. Peter Calabrese, Johns Hopkins. Dr. David Hafler, Yale. Dr. Mara Casey, Cedars-Sinai. Dr. Adam Kaplan, Johns Hopkins. Chad King, our MS advocate. Mr. Rhonda Voskuil, Dr. Rhonda Voskuil, UCLA. Dr. Emmanuel Wabant, our Race to Erase MS medical director, UCSF. Dr. Howard Weiner, Harvard. Dr. Vijay Yadav, Oregon Health Sciences University. And of course, Nancy Davis, our founder of the Race to Erase MS. It is my pleasure to introduce our founder, Nancy, to kick off our panel discussion.
Welcome, everybody. This is our 31st Race to Erase MS and our 31st forum the day after. And this is what it's all about. We do a very big event, and last night was spectacular. So many wonderful things happened. We raised lots of money. We had amazing entertainment, and I'm sitting next to one of the entertainers from last night, Chad King, from A Great Big World. And he performed and sang the most amazing songs, and he's uber talented, and he's going to talk a little bit today about his journey with MS. And the event last night, we did really well. We're so excited that after 31 years, we're able to do that. I have multiple sclerosis. I was diagnosed 32 years ago, and in that moment, there was no known cause, no cure, no drugs on the market to help stop the progression of MS. I was told the most I could look forward to in my life was to operate the remote control of my TV set. And I was a young mom. I had 3 kids, and I had a lot of dreams, a lot of hopes, and a lot of things I was going to do in my life. The idea that I would have MS and not really be able to live out any dream or be a parent to my kids. I know tomorrow's Mother's Day, and all us mothers here think about, what an honor it is to be a mom, but it comes with a lot of obligations when you're a mother and you give birth to a child, and it's really your job and your duty to provide a lot of security for your children, and you really want to be there for them. But the idea that I was going to put my children in a worse position and not be able to be there as their mother and show them, life and the best things I could, it made me very scared and very nervous. I went to many, many doctors and many hospitals and got many opinions, and some of those hospitals and doctors are representative here. And what I found in the very beginning was everybody was so negative that there would never be any cure or any medications for MS. And when I listened to the most brilliant doctors around the country, a lot of them were doing the same exact research as each other, but they knew that they were the only one doing it. And I said, well, they're doing that here, they're doing it there. And along the way, I thought if we could put the best and the brightest to work together as a team, to not work against each other, but work together, we would really find something. And so we were way virtual before anybody else was. I hate to say that. And I'm terrible with a computer, by the way. So that I thought of something virtual back in the days, kind of a miracle unto itself. But we have these doctors here today. Many of them have been with us since the inception. I have the highest regard for them. They have developed the most incredible things. The person who was diagnosed 32 years ago faced a very bleak future. There were no medications. There was no hope of any medications. Today, there's 24 medications on the market. There's a lot of choices. These medications are making people have an independent, good quality of life. But we're so excited that we've been a part of doing pilot studies to develop many of these medications, and that is amazing. I'm so thrilled. But as we are here today, a lot of people have chronic progressive, primary progressive, and we need to do more. We have to do more. We need to find ways of remyelinating, restoring nerve damage, finding other things that are going to help absolutely every single person who lives with MS. That is our goal. We are the race to erase MS. We are in a hurry. I'm an impatient person. We need to cross that finish line and we need to find a cure for MS. So thank you, everybody I'm with today. Thank all of you for being here. And we want to do everything possible to find a cure as soon as possible.
Thank you, Nancy. The first person speaking on a topic is Mark Barondis, and he's going to tell us about his experiences with MS.
You need to press right here. Morning. First of all, thank you, Nancy and Claudia, for allowing me again to participate in this very prestigious panel. I sit before all of you today, not as a medical professional. I'm just a lawyer by trade. And more importantly, I'm one of many men that lives with multiple sclerosis. It's been a journey that began when I was 40 years of age. Now it's almost 24 years later, and MS has continued to test me in ways I never imagined. Yet it's a journey that's shown me the strength of the human spirit. It's allowed me to become a part of this wonderful community of medical professionals and fellow patients battling this perplexing, and as you can tell, it's a very challenging disease. Most people picture MS as a women's disease. After all, the media presents the example of the courageous stories of people like Terry Garr or Selma Blair or Christina Applegate as they battle the disease. And I'm glad that their names draw attention to MS. But the truth is, MS hits men too. People like me, people like Chad, sitting on the front row, to a tune of about 1 in 10 cases. And that's a pretty sobering statistic. But here's another one for you. MS also appears to impact men in a more aggressive manner. Our bodies are obviously built differently, and they seem to handle the neurological challenges that the disease presents a little bit less gracefully. For me, I started with relapsing remitting MS. Today, I have secondary progressive MS. Secondary progressive, as many of you know, is a form of the disease that has far less options in terms of treatment. But hopefully the people on this panel are working hard in order to move forward in that area. For men, our symptoms manifest with a much greater severity, leaving us grappling with challenges that I'll be honest, at times seem a bit insurmountable. Men have worse recovery from relapses, have higher rates of cognitive impairment, and like me, are more likely to develop progressive forms of MS, which are associated with greater forms of disability. Now, sure, fatigue hits all of us. If you haven't had it, fatigue is that bone deep tiredness that it's hard to explain unless you've actually experienced it. But with men, MS also experience a faster progression of muscle weakness, of balance issues, sexual dysfunction, and some real fun bladder issues. I could tell you that I joke around that I usually wake up at about 3 a.m. and now, sorry to be tawdry about this, I seem to pee in Morse code. It's not always glamorous. But here's the real thing. Men are wired differently emotionally too. We tend to bottle up things, to hide things. We tend to conceal MS because we feel that people will pity us. Emotionally, men with MS face a unique set of challenges, from societal expectations of how a man should be internalized through various stoic stigmas. From a young age, we're taught that we should never show weakness. Yet in the face of MS, vulnerability actually becomes one of our greatest strengths. But at the same time, MS honestly can be a lonely journey. The fear, the frustration, the anger, the pain, it festers if we keep it all in. So men with MS, I urge you, Talk to your spouse, talk to your partner, talk to your friends, your doctor, your therapist, whoever will listen. Most psychiatrists, like Dr. Kaplan, will tell you that a good rant is better than a silent scream. I'd be remiss in closing if I did not offer the amazing medical professionals in this room a heartfelt thank you. You dedicate your lives to unraveling the mysteries of this disease, to finding that elusive cure. We, your patients, are your partners in this fight. We'll continue to participate in trials, answer your questions, even be your human guinea pigs, as long as you keep pushing forward. Your unwavering commitment to erasing MS from our lives, your tireless efforts to ease our pain and restore our hope are nothing short of heroic. To my fellow MS fighters of all genders, this journey might be tough, sometimes even downright brutal. But listen closely, and I've said this before. MS does not define us. It's a part of us. It's a pesky and unwelcome part, but a part nonetheless. In the face of adversity, I urge all of you to find strength in your vulnerability in the depths of despair. Find hope in the kindness and care of others. And in the darkest of nights, find solace in the knowledge that we're not alone. And remember, even though during our struggles, there's still room for lighthearted moments. People are often kind to me and come up to me and say, "Mark, you look really good." My usual reply is to suggest that they see an optometrist or an ophthalmologist. So while laughter may not cure MS, it sure makes the journey a bit easier. I await the day in the future when we'll be free from MS. Nancy, we're in this fight together, and together we will win this race to erase MS.
Yeah.
Apologize, I have to leave to go catch a plane flight. Thank you all, though.
Thank you, Mark. Mark has a flight to catch. So thank you for taking the time and being with us.
Wait, Mark, thank you so much for that. That was really nice. It makes me think, I know this is completely out of what we're supposed to be talking about. It makes me think that we really haven't funded anything that's specific to men's, like a men's study to understand that. And I think that's something we should talk about doing.
Let's do it.
Because I see several men in this room who I know have MS, and I don't think we've ever done specifically something for men. And I think it's time that we do that. So Chad will speak too, but I think we should challenge all of you doctors here today to find, I don't know, to come up with an amazing study that deals with that, because I think because it's only 1 in 10, you look at the 9 out of 10, you got to look at everybody. That's the big deal. And I know lots of men who have MS. So that what you said just made me think we've got to do something that's specific to men.
Have a great evening.
Safe flight.
All right, so to continue with the topics.
It looks better to,
Oh,
we
sorry.
lose his space and whatever.
Mhm.
I'm always about aesthetics.
Yes, so, okay,
Hmm.
to continue with our topics. Next, are new drugs to slow down disease progression. Dr. Liliana Amascua, USC.
Thank you, Nancy. Thank you, Claudia, for all your amazing work. It's really exciting to be here every year. And today I love seeing the room full. And I know also we have all the other individuals on Zoom. First of all, I do want to start by saying that there are, just like Nancy expressed, there are over 24 disease-modifying therapies. And we have learned really well that we can take care of inflammation. And this needs to start as early as possible. And very highly effective therapies are out there. There's a number of them today here representing a lot of these wonderful drugs that we do have, such as Ocrevus and Pramvi, and I think I see also natalizumab. And these are what we consider some of our highly active, high efficacy drugs that can work rapidly and effectively to prevent relapses, delay progression, or stop regression. And there's a lot of hype out there, of course, some newer therapies that are out there being tested with some, some of the first of what we call BTKIs. And these are small molecules that we understand that could work better because they can enter into the CNS and basically get rid of what we hoped to see is decrease the inflammation that's trapped inside the brain. We do have some, one of the trials that was recently reported, which was not as, happy of results that we wanted. So basically there was some, did not meet some of its primary endpoint. But it did show though that comparing it to one of the disease modifying therapies that we know well, Aubagio, that one worked really well. Now, of course, this is still, we're trying to better understand what went wrong. And it could be an issue of that, the population is now showing that these patients had very little relapses. Of course, there's a lot of things that could have gone behind that where we're diagnosing MS earlier or they didn't have as much disease activity for us to see that it could work better. However, there's a number of them out there of BTKIs that are still being investigated, and we hope to hear more about those results. Where it is exciting, though, is to see if they will work actually in primary and secondary progressive MS. And we're hoping to learn more. Now, these trials have been ongoing for a little bit longer than we expected, and that's because at the beginning of the trial, well, not at the beginning, but sort of in the midst of the trial, there was a high signal with liver toxicity. However, most of them have resumed, and we're hoping to find out if they will be effective. USC is part of one of those trials, and so we're hoping to learn more. But there's other exciting news for the progressive forms and secondary progressive. But before I say that, I do want to state that there is an effective drug for primary progressive, which did show modest effect, and we use it quite often, and that's ocrelizumab for primary progressive. Any secondary progressive MS that is active, and active means that there's been recent MRI activity or recent, inflammation by a relapse can go on to any of the disease modifying therapies that we do have. Mitoxantrone is also approved for secondary progressive, but we don't use it that much, and that's just because it's highly toxic. But that was certainly a drug that we used in the past. But there's other really exciting treatments out there that probably Dr. Howard Weiner can speak to. One of them, it's a treatment that is given intranasally, and it's shown right now to be effective, at least in modifying fatigue in 6 out of 8 patients, and he can probably speak to more about that. It's a phase 2 trial. What it's doing, it's blocking CD3, a protein found on the surface of T cells. So we have really great therapies for B cells, and now it seems like also now focusing on T cells back up again. Another one is a trial that will look at T regulatory cells as well as a treatment for primary progressive MS as well that we're hoping to start at USC. There's also another treatment called frexalimab, which is an anti-CD40L antibody that blocks a certain pathway that's also part of a T and B cell function. So there's a lot of exciting new novel therapies, but there's also looking at therapies that have been used for other conditions. And this includes metformin, which is being looked at from different clinical trials, but also UCLA. And I think Dr. Boschkel can speak to that one, as well as other supplements like alpha lipoic acid. And I know there's probably some, more knowledge of that can be spoken by Oishia, by Dr. Vijay. So really exciting times, I think, for primary and secondary progressive MS. But for all those with relapsed and remitting MS, if things are not working, there is many, many options.
Thank you, Dr. Amescua. And next is new immunology updates in MS, Dr. David Hafler from Yale.
Thank you. Thank you, Claudia. Let me start with a question. which I've asked many times before. Do we know the cause of multiple sclerosis? Anyone here think we do? Besides Howard? But of course, we never really know causality because you don't know what you don't know. What we do as scientists is create models. And I want to give a brief narrative about a study that was funded originally from the Nancy Davis Center, but was to understand how does B-cell depletion work in patients with MS. It has dramatic effects in very early disease. And using a new technology, we're able to address how the drug works, which has given us insight into the cause of MS. So what causes MS? The working hypothesis is that there are autoreactive T cells, a type of immune cell that recognizes myelin. That T cell becomes activated, perhaps related to EBV. There's a lot of evidence to suggest that, and the activation of those myelin reactive T cells then traffic from the blood into the brain, attack the myelin, and initiates the disease. Now, we know that if we deplete B cells, we say deplete, we deplete them from the blood, but they're still in the lymph nodes, which is very much part of the immune system. The question, how does the drug work? So let me try to give a brief narrative of what we found. The paper is actually just submitted for publication. So the technique we used doesn't start with a hypothesis. Now, you probably learned in school that you start with a hypothesis. You really don't do that. You start with an observation, and we have new technologies, dramatic technologies, allow us to address questions where we come up with molecular observations, which then lead to the generation of hypotheses. So what we did was 20 patients pre-post treatment with B-cell depletion. We then did a technique called single cell sequencing. We take each individual cell out of the blood, spinal fluid, and sequence the heck out of each cell. It's a dramatic new technique, changing medicine. And with this technique, we can ask, how do the cells change without any preconceived notion? And what we found, to my big surprise, was that the big change wasn't in T cells. Obviously, the B cells are gone. But there's another type of cell, a macrophage type cell, which usually chews up foreign things. It's the macrophage that increased in the spinal fluid in the blood. That was a surprise. And these macrophages started to secrete a highly inflammatory hormone or a cytokine called TNF, tumor necrosis factor, TNF alpha. Now, that was a surprise. Who would have thought that B-cell depletion would lead to a marked increase in an inflammatory cytokine? But then we went on to discover that that inflammatory hormone, a cytokine, was triggering suppressor cells and increasing the ability to suppress, and it was associated with loss of myelin reactive T cells. And this is important because it really provides the first evidence that we are correct that MS is a disease caused by T cells attacking the myelin, because this very dramatic treatment basically eliminates autoreactive T cells by this inflammatory cytokine or hormone inducing suppressor cells. So that's how the drug appears to work in part. And it's really quite exciting. Also may explain why the BTK inhibitors didn't work, because they have a very different mechanism of action, and by depleting the B cells, this other population came up. Now, I want to just end with something related to treatment of progressive disease, which relates to B cell depletion. There is a type of cell called a CAR T cell. And these are cells that have the anti-B cell antibody on their surface. Now, Ocrevus works a bit in primary progressive disease, but not that well compared to what it does in relapsing remitting disease, where it's incredibly effective. So why doesn't it work? Well, one possibility is that this antibody, which attacks and destroys the B cells, doesn't get into the central nervous system. And with this new CAR T cells, in fact, these CAR T cells do go into the brain, into the central nervous system. And we know from treatment to lymphoma that has dramatic effects in eliminating B cells. So there will be a clinical trial with these CD19 as like anti-B cell T cells. to see if that works in progressive MS. And that's going to be a very exciting study. It may work, it may not work, but if B cells are involved in causing the disease in the nervous system that is behind the blood-brain barrier, we'll find out with this clinical trial. So very exciting times in the field of immunology. We have incredible new tools to begin to understand the cause of MS and to develop new therapies for the disease. So I'll stop there. Thank you.
Thank you, Dr. Heffler. And next, exercise and physical and cognitive rehabilitation, Dr. Vijay Yadav.
Hi, everyone. Good morning. I think what I'm going to talk about exercise is in the past when, or I would say when I say past, about 30, 40 years ago when MS, we did not really have treatment options and people would get disabled quite a bit despite like the steroid use or whatever. People were told to actually just not exercise and rest. That's a wrong thing. That's absolutely a wrong thing. Resting, yes, it's okay to do, but you should not be staying in bed or like, not really moving. So that's absolutely a myth. In fact, in the last 20 years, research has shown that people who exercise or MS people who exercise, they do much better in many, many aspects of their overall symptomatology. Whether exercise can directly impact remyelination, I think that's being tested right now. In fact, one of our colleagues at OHSU is doing exact same study about effect of exercise on remyelination potential. In general, if you look at people who with MS who are severely disabled, for example, if they're wheelchair bound, they can also actually do exercise. And there are newer technology now which can help them in moving much better. So I'm not sure if you heard about this technology called ReWalk technology. ReWalk is basically computer aided technology, which was developed by the Department of Defense for our people or veterans or army people who were injured in the war and had spinal cord injury. So those people who were completely paralyzed, either quadriplegic or paraplegic, they are able to walk with the use of this device called ReWalk. ReWalk has been tested in few of the MS patients, and I think that research will go on. And I think the technology will definitely help us in improving the disability in our MS patients who are unable to do it themselves. There's another device that has been in kind of in press called PONS device or portable neurostimulation device, which is a tongue stimulator. We have done a small study with the company and looks like it's promising, but again, those are studies which are going to show, results hopefully in like, this year or next year we'll get some more data. In general, exercise, if anybody does exercise, they will see improvement in their overall fatigue level. So absolutely, if exercise can improve fatigue, it improves the cardiovascular health, which in general will improve the brain health. So cardiovascular health and brain health are directly connected, so they're not separate at all. So I think definitely that needs to be kept in mind. When you're exercising, you also need to nourish yourself very well. So you can't be eating poorly and doing like rigorous exercise. So I think nutrition is a key element of, and supplementing that to the exercise can definitely help our patients with MS. What else I want to talk about? One more thing, people who are disabled and are not able to move, especially when we talk about progressive MS, we feel like, MS is progressing. One of the reasons that MS could be progressing is people are not moving enough. So what people can develop is called muscle disuse atrophy. So we're not using the muscles, they will get sort of atrophied over time, and then your function will get poorer and poorer, and you'll feel that MS is getting worse. So that's something to really keep in mind. Make yourself moving all the time, even if the function you feel is getting lost. So work with physical therapists, work with your doctor, work with rehab doctors. There are a lot of resources now available through National MS Society or other societies. So I think exercise absolutely is a critical component in addition to the nutrition and the disease modifying therapy for optimal management of MS. So absolutely, really important. Thank you.
Thank you, Dr. Yadav. And next, new diagnostic criteria for MS, Dr. Peter Calabrese, Johns Hopkins.
Morning, everyone. First of all, thank you, Claudia. Thank you, Nancy, so much for your perseverance and keep doing this. And sometimes when we get tired, you actually really inspire us. So thank you for everything you do. And I also like to thank the audience, because seeing you guys out here people who live with this disease or have loved ones. It's inspirational for us. It makes it more real. And I think that's important to have this kind of crosstalk. So I always enjoy doing this, and happy Mother's Day to all the moms out there. And super excited to see a junior scientist here taking notes. And so that's fantastic. We need the next generation of scientists coming up. So my discussion today is about the diagnostic criteria. We call it the McDonald diagnostic criteria because it was a famous scientist who first proposed these criteria decades ago. And every 5 or 6 years, experts from around the world get together and kind of revisit how we diagnose MS. And you might think, well, that's kind of silly, don't you already know how to do that? But MS, as you've heard, is a variable disease. We call it heterogeneous, and it comes in different forms and flavors. And so it's not a bad idea to kind of revisit the technologies that exist so that we can diagnose it earlier and make sure that we get the diagnosis right. So many of you might not realize this, but over 10 years ago, Nancy, who's busy curing MS, also realized that this was going to be really important. And she realized that imaging was one of the critical ways that we diagnose MS, and formed a subcluster of the race that was an imaging consortium of experts within all the centers, and really kind of inspired them to develop new tools to diagnose MS. And so I'm going to mention some of those, and then Dr. Marwa Casey is going to do the deep dive on that later. But it really started all right here. And there's now a group called the North American Imaging MS Consortium that Nancy started, and lots of other centers beyond the race centers have now joined in on that. So it's really an amazing accomplishment, and it really kind of sparked these new MS criteria. So how do we diagnose MS? Well, it's hard, right? Because it's, as the name implies, multiple areas of these sclerotic or scarred lesions, and they need to be in the brain or the spinal cord, which are the sites that MS affects. But we can't do a biopsy. This is not like cancer where you can put a needle in and take a piece of the tissue. It's in the liver and the lung or in your skin. It's the brain and spinal cords, and we don't like to do that if at all possible. So imaging turns out to be very useful as a way of further confirming the diagnosis. And some of the imaging tools we have today allow us to do what I like to call a virtual biopsy. They're so good that you can actually see the tissues at a level that's almost like using a microscope. So we have to, of course, people have to have some kind of clinical event. And typically, decades ago, there had to be 2 clinical events in different parts of the nervous system at different points in time. But we know that there are parts of the brain where you can have these events happening and not even know about it. In fact, when I was training, it was said that for every one clinical event, there could be 5 or 10 lesions that were forming on the MRI. And that was in the late 80s and early 90s when we realized how important MRI was. So MRI became part of the diagnostic criteria. But now we wrestle when we see people with MS or possible MS as to whether the white spots that we're seeing, are they truly demyelinating lesions like we see in MS, or are they white spots related to other diseases? And this has become a really tricky area in making an early accurate diagnosis, because we know that if you have head trauma, or if you have diabetes, or even if you have migraine headaches, you can get nonspecific white spots. And so this North American Imaging MS group has developed a technique to find a very characteristic lesion of MS where there is a vein in the center of it. And this was described over 100 years ago by pathologists, but now using MRI, we actually have the tools to see which of those white spots have a central vein. And again, Dr. Casey is going to tell you more about that. Another kind of MRI characteristic of MS is a lesion that has an iron rim on the outside of it. And it turns out that these are chronic active lesions, and iron actually shows up dark on the MRI. And so we call these phase rim lesions, but that's the particular sequence of the MRI that shows these. And if more than a certain number of your lesions have these phase rims, that's highly suggestive that not only is the disease MS, but that it's in a chronic active phase. And this is important because it's a tool we can use to test drugs for worsening or progressive forms of MS. The other big news in MS diagnostic criteria is the ability to detect optic neuritis really early. Some of you guys may know that you can lose vision in one eye, it can be painful. And when it's very dramatic vision loss, we can often detect it clinically. But we know that a lot of people have optic neuritis events that we're missing. And a colleague of mine, Laura Balser, was using low contrast cards, which simulate nighttime vision, and found that some people were legally blind at night, but when they were tested at the eye doctor's office on a Snellen chart, they had 20/20 or 20/25 vision. So she had this hypothesis in the 90s that there were more people out there with optic nerve damage than we realized. And then technology came along, which I'm very enamored with, called optical coherence tomography. So this is a device that we now have in a lot of neurology offices that shines light through the pupil into the back of the eye and takes a picture of the back of the eye and gives us nearly microscopic resolution of those tissues. Now, that's the one part of the brain that you can see from outside without penetrating the skull, because you're going through soft gelatinous tissue with the eye. And these pictures are so accurate that we can detect subtle changes in the back of the eye that are suggestive of optic neuritis. And the McDonald Diagnostic Committee voted that OCT should now be used to detect these subtle changes in early optic neuritis. So hopefully we can be sure that it's MS and get people on these amazing 24 therapies sooner to stave off the progression of the disease. So I think that's very exciting news. And we also are thinking about using these imaging technologies for monitoring new therapies and prognosis, which you'll hear from Dr. Casey. So basically, I'm just going to end and say that we're going to keep trying. We're going to persevere. Nancy's been inspirational. I was talking to my friend Adam Kaplan last year about what we can do to kind of mix things up and try something new. And he looked at me and said, "Peter, you could start with a new wardrobe." And I said, "What do you mean?" He said, "Well, you always wear blue or white shirts." And I do. So today, I'm shaking it up a little bit. Try something different. Because I won't stop till we cure this disease. Thank you.
Thank you, Dr. Calabrese. So next, on the topic of sex differences in susceptibility and progression in MS and treatment, Dr. Rhonda Bosco.
Thank you. And again, recapitulating, what Peter said, I think this is amazing what Nancy does. I don't know anybody who can get all of us in the same room in the world, actually. I don't know. She just isn't, it's inspirational. And she drives it through, getting to our hearts and knowing that this is the right thing to do. So I want to talk about these 6 differences that were alluded to by Mark Banderas earlier. I've been a part of a really international organizations who have said we need to embrace these 6 differences. First of all, document them, make sure they're very real, and then embrace them and not lump them together. There is equality, but it doesn't mean the sexes are alike. They're different. And the reason that's important, because there may not be a one-size-fits-all treatment for both sexes, all ages, et cetera. So and what kind of observations am I going to touch upon? And that is, as was said by Mark, females are more susceptible to MS. There's a higher propensity of MS. There's more women who have it. And so what we've done through funding through Race to Race MS is we've looked for why, and we've found a gene on an X chromosome gene that leads to increased inflammation. And this is relevant not only to MS, but it's also true for other autoimmune diseases where women have lupus, rheumatoid arthritis, et cetera. So how does this X chromosome gene work? It's actually quite amazing. The X chromosome gene can regulate expression of all the other genes. And there was a paper recently in Science that showed that 1/3 of all genes in the body and all tissues are differentially expressed in females and males. So of course they're going to get diseases differently. Of course they're going to respond to treatments differently because they're different genetically with the genes they're expressing in 1/3 of the cells. Sometimes it's higher in females, sometimes higher in males, the particular gene, depending on the tissue in the cell. But the point is we just have to figure out what is the cell problem, the tissue problem, and target it specifically a little bit different maybe in females versus males. So the X chromosome gene is important because it drives pro-inflammatory effects. And we presented yesterday at the scientific symposium. This was funded by Race to Race MS. And now we've genetically shown that we can block it, and that reduces inflammation in a peripheral immune cell as well as the central immune cell of the brain. And now we're starting a trial that's also been funded by Race to Race MS, and that is a trial of metformin. Metformin is a cheap, inexpensive, safe drug used for diabetes, but interestingly, it can block this gene, this X chromosome gene. So we're now doing a trial to see what would be the effect of metformin treatment in MS, looking at a cell in the brain that is showing this expression and inflammation to try to block that. Of course, a different question you may have already thought of, and that'll be the next question, is would metformin differentially affect females versus males? It could, because the females have 2 copies of X and the men have 1, it's XY. So that's another question. But the first question is, what's the gene? What does it do? And how can we block it with something that's safe and inexpensive, right? So the second thing I want to touch upon is what Mark said about males, men. Yeah, there's a difference, and he's exactly right. Men, while they're less likely to get MS, when they get it worse. And so we've spent quite a bit of time actually focusing on this. The age in which these data generally come from are from clinical trials, which are generally done by these companies that are some of these companies represented here, and groups here have worked on. The ages generally in these trials are around 18 to 65, but the mean and median ages in these trials are about 40 to 42. And so in these trials, when you look at data from just like placebo treatments, you find that men do worse with respect to disability progression. It's exactly what he said, and he's right. And so that means the time to go from having given disability to worsening is shorter for men. And again, the age is about 40 to 42, the mean age. So the question is why? Well, I'm very simplistic. It could be XY gene effect, or in the brain probably, or it could be that something like testosterone is protected, but it's being lost. And we focused a lot on testosterone. We're doing the genetics too, believe me. But with respect to testosterone, andropause actually starts early. Menopause is at 51.5 is the average age for menopause. Actually, andropause starts at age 30 and it goes so slowly. Testosterone drops to age of 70. It's 30 to 70. It's a very, very slow drop. So if you think about that mean age of 40 to 42, that's actually at a time where men have going through andropause for about 10 years. Women are doing pretty good up until they're 50, 51, 52, right?
Then
And-
it's all over.
Well, that's the last point. That's my third point. There's 3 points. One's genetic, the X chromosome. Second, my point's testosterone. The last one's going to be menopause. So Nancy's ahead of us like always. So she thinks ahead. So it's true. So back to the testosterone. What is the data that testosterone's they're both neuroprotective. Estrogen and testosterone are both neuroprotective. And that's been shown in a vast array of literature. They're both neuroprotective. They're both good. It's bad to lose either one. And what we recently have a paper on there, but there's differential timing in which they're lost. Men lose it very slowly, and women maintain estrogen up until that time. Testosterone is converted to estrogen in the brain, actually. So you start with testosterone, it's converted to estrogen in the brain, and you're binding estrogen receptors. That's how the neuroprotection is occurring, okay? So just bottom line is they're both neuroprotective. The timing of their loss with aging is differential, with men being slow and gradual, starting earlier, and women maintaining. Now, the other evidence that the role of testosterone, let's talk about that a little bit more in men, because we say we haven't talked much about men, so let's do it. All right, so men, I made,
Only disease that isn't surrounding, women.
yeah, exactly.
That's
No, you're
interesting.
absolutely right. So let's go there, and we can even think about the next study, which I started thinking about when you said you were going to fund it. So let's say it. Okay. Nancy says, let's do. I'm like, I have a note here to the guy we've got at the VA. Eric can send out a proposal, but
What have you already come up?
what have
with?
we already done? Okay, let's talk about what's been done before we
The
can talk about
last
what's been
20
done.
minutes.
Okay, sorry. So it's known that men with MS have lower testosterone levels than healthy men. And it's also known that men with testosterone level, MS men that have lower testosterone levels do worse with their disabilities than the men with MS that don't have it so low. The bottom line is having low testosterone is bad in men with MS. And furthermore, we've shown that at this age, around those early 40s, they have worse brain atrophy in these particular regions. So they're worse clinically, they're worse on MRI, and it's associated and correlated with lower testosterone. We actually did a trial of testosterone treatment in men with MS. It was a very small pilot trial years ago, and we treated men with MS with androgel, and it was treated, we used it every day. We did MRI, and we showed that it slowed some of the brain atrophy in men with MS. And so I've been so busy doing so many things, but we should return to that because we understand more about how it works and why, different outcomes. I think that what I'm doing now clinically, you say, what are we doing now? And that the answer is if a man he goes to the doctor and says, I've got MS and I'm concerned about, it might be low in the first place because I have MS, because that tends to be the correlation. And if they're getting older, say, what is my testosterone level? And they just basically put it in, instead of the low normal range where they generally live, just have your internist put it in the mid to high normal range. Of course, check for prostate cancer like anybody would with given testosterone. We know a lot about how to get testosterone safely. It's been done a million times. So that's what I would recommend for now, until these trials all get done and they get done beyond just a pilot to a phase 2 or hopefully a phase 3. That's what I would do. I would make sure it doesn't go into that low normal range where the MS men tend to live. Get it up there in mid to I wouldn't go above normal either, but I would go mid to high normal. I wouldn't let it go low normal. Okay, so the next thing I want to finish with the menopause thing. So women do great up until they're about 50, 51.5 is the median age for menopause. Of course, it ranges over about 3 to 5 years. And then what? Well, it's bad. It's really bad. So what happens is they lose their neuroprotective estrogen. It's not even gradual. It's abrupt. It's bad. And it's more than just hot flashes and cognitive issues. Even in healthies, MS women, their disabilities worsen. It's been shown that worse menopause is bad for healthy women. Even they have cognitive issues, cognitive domain specific problems. They have certain parts of the brain have abnormalities in atrophy and connectivity. So this is a problem. It's a menopause is a bad thing. So we've spent a lot of time. Well, and I'm even working with the UCLA Menopause Comprehensive Care Menopause Program now, and I'm the neurologist to work on this cognitive issue of even healthy women with menopause. And we've actually started a company around that with UCLA with the patents that I have. It's called Cleopatra, and a nonprofit for people who can't afford it, even though it's cheap. And actually, the Biden White House initiative has their initiative for women's health research. I think you might have seen Haley Berry on the news with the Senate's got a proposal. This is a time menopause is really being recognized, and the White House has recognized it. And also autoimmune diseases in women, menopause in women. This is really getting exciting, and we've got things that we're doing. These are becoming treatments with last thing is the estrogen that we're using is novel in this sense. Okay, women need estrogen. Estrogen's neuroprotective. Suddenly losing it is bad. Menopause. We can't replace it well with these old drugs that have been given. So the way to do it is to use a different estrogen that binds this estrogen receptor beta in the brain and causes neuroprotection, and it binds very weakly to estrogen receptor in the breast. You maximize efficacy, which is neuroprotection of the brain through one receptor, and you minimize the binding to a deleterious effect on an estrogen receptor in the breast, because everybody's scared of breast cancer and they should be. So I don't use that. We use something else to target getting positives and minimizing negatives. Okay.
Thank you, Dr. Bosco. And next we have MS treatments and challenges, Dr. Howard Weiner, Harvard.
So thank you very much. First of all, I want to thank Nancy for all that she does and did and continues to do. The Race to Erase MS started in Colorado, where we actually had a ski race. And I was there. I've been here since the very beginning, and it's just been amazing to see what you've done. I remember Nancy's parents, especially your father, Marvin Davis, who loved deli food. Why is that important? Because my parents owned a deli in Colorado, and my father said, Marvin ordered the most food than anybody else. Super achiever. Now, David Hafler was just in Denver and he was at the deli. He couldn't eat the sandwich. I had a picture of it. Anyway, so Nancy, thank you so much for all these years, and we love you and we continue to support you in everything you're doing. We'll bring sandwiches next time. So let me look at my topics here, and let me talk a little bit about the 2 stages of MS. and what our big challenge is now in multiple sclerosis. You heard that we have many treatments for MS. This is for the relapsing form, okay? And those first came out in the 90s. And probably one of our best treatment for the relapsing forms are anti-B cell therapies like Ocrevus and Kesimpta. And they really, really work, and we like to use them. And Dr. Hafler, with his expertise in immunology, has begun to understand what they do to T cells, that he's the only one who can do that. But we now know that it's true. We now know that even though we can shut down all the relapses, underneath this, progression may be going on in the brain. And even though people have no more relapses, some of them, not all of them, some of them may become progressive. And we don't have good treatments for progressive disease. So this is something that we've been focusing on. We've done it in a number of ways. One way is to see whether we can develop blood tests to see whether we can tell people who are relapsing and seem to be doing well may be becoming progressive, so then we could figure out how to treat them. The other thing that we're doing is we came up with a new therapy. I call it a nasal spray because it's easy to understand. It is a nasal spray. It's giving a monoclonal antibody nasally that binds to the T cell. We talked a little bit about it at our scientific symposium yesterday. And we've treated about 10 people with progressive MS who aren't responding to B cell therapy. And we've seen what we would consider very dramatic findings. The progression slowed down or stopped, and we saw decreased inflammation in the brain. So we're very excited about this. Now, that's an open label study. You can't prove anything with an open label study. You do an open label study to get a hint of what's going on. We think there's something there, so we're now doing a double-blind trial where some people will get the nasal spray, some people won't, and many of the centers in the Nancy Davis Center Without Walls are participating in this trial. So we're very excited about that, and we look forward in the coming year or years to say that it worked and that people could take a nasal spray. Interestingly, there's no side effects, which is very nice. And it could be given with the anti-CD20 therapies. The last thing I'll say, it hasn't come up. We had Dr. Lori Cox here. Another area that we're very interested in is the microbiome and the trillions of bacteria that exist in the gut. And we've found different patterns with the microbiome. Everybody asks, well, what probiotics should I take? We don't know exactly, but we do think there might be some. And we're now going to do a trial, one of the first trials in both relapsing and progressive MS, using a unique probiotic and see whether it helps. And if it does, that could be something else that patients could use. So we're very excited about what we're doing. Science is hard, biology is hard. If we knew the exact answer, we would just do it, but we can't. We got to fight it out to win the race. And I'm very excited about where we are to collaborate with all the people at the Center Without Walls. And again, Nancy, I thank you very much. Thank you very much.
Thank you, Dr. Weiner. And next, we are happy to have Chad King sharing his story about living with MS.
Hi. Hello. Hi. First off, thank you. Thank you for having me. Thank you for having me. This is so inspiring to be here with all of you doctors, giving me hope, giving all of us hope. It's beautiful. I'm not a doctor. I'm not a doctor. Gotta say it. I'm someone living with MS, and last night there was another part to this event where I performed with my friend Ian, and it was a struggle for me, and it's been a few years since performing, but the room was so warm and inviting, and it was so beautiful, and it was the first time that I sang in a long time, where I felt comfortable to sing, because MS is affecting my voice, and I've been scared to perform. Anyway,
You're amazing, by the way.
thanks. I was diagnosed in May of 2007, senior year of New York. I was at NYU, New York University. And when I was diagnosed, I didn't believe it. I didn't want to believe it. I felt like, I don't know, there's no way that I could have MS. I don't even know what that is. I've never heard of it. I'm fine. I'll be fine. I'm just gonna ignore this. And then I went to 3 different neurologists who all said, yeah, you have MS and you better look at this, but I didn't. And my career was sort of taking off, if you want to call it that. And I was finding success there. And I was like, okay, I'll deal with that later. The MS piece, I'll deal with that later. And it was a beautiful ride, career wise. And then it wasn't until maybe 3 or 4 years ago, that MS started catching up with me. And finally, I had to really consider medication because my walking became unstable, and it was hard to walk further than a half a mile. I started getting fatigue like midway through the day, and it was fatigue that you can't ignore. It was like I had to lie down. I had to close my eyes. My left side, my whole left side, started to become weak after like 2 p.m. and like playing guitar was impossible for me after 2 p.m. And I would say over the last year or two, that's when it started to affect my voice too, and my singing just hasn't been the same. When the MS started affecting my walking a few years ago, that was when I started to consider medication. That was when I considered Ocrevus, and I'm on Ocrevus right now. And thankfully, I've been on the MRIs. I've been stable, which is wonderful. But thanks. The doctor, my neurologist in New York, says that I'm sort of on the cusp of relapsing, remitting, and secondary progressives. Yeah. And I'm I've gotten to the point where now I have to adapt and adjust to this new reality. And I'm sort of forced to, instead of, I know I could have listened to the doctors. I probably should have listened to the doctors, but I didn't. And I could have gone on a medication beforehand, but I didn't. And that's okay, because I'm here now, and that's okay. And it's beautiful where I am. But this diagnosis for me, I've gotten to a place where this diagnosis has become a blessing. This diagnosis, as strange as it sounds, I'm actually thankful that I was diagnosed, because I feel like I know my body better than I've ever known it in my entire life. And it's so wonderful to be able to know how my body is feeling in these moments and really tuning into it. And I feel like I have not been doing that. So thanks. And I think I think if there's a silver lining for me, that is the silver lining. And I need to embrace the changes that MS is bringing to me. And so last night also proved to me that it's okay, Chad. Like you sing differently, and that's okay. And that it was tough to really embrace, but I feel like last night proved to me that I can, and it's really amazing when I do. Anyway, thank you again. Thank you for listening to my story. Thank you. Thank you. Thank you for having me.
Just apologize to catch the last flight out to be with my family for Mother's Day. So thank you all for having us, and thank you.
Yeah.
Thank you, Chad. We appreciate that. Next, new MRI markers for MS diagnosis and prognostic. Dr. Marwa Casey at Cedars-Sinai.
Good morning, everybody. I'm Marwa Casey. Thank you so much to Nancy, Claudia, Dr. Waban, and to Liz for having me here. I'm new to this patient forum. I'm very excited to be with you here this morning. I'll briefly tell you who I am. So I'm a neurologist at Cedars-Sinai down the road. So I see some familiar faces in the audience. And as an aside, my mom has MS and she was diagnosed 26 years ago. So the difference between being diagnosed 30 years ago and 26 years ago, there were a few medications on the market at that time. Unfortunately, they didn't work very well for her, which is a whole separate story. She's fine. She's traipsing around Spain right now. So happy Mother's Day to my mom. And part of why I became an MS specialist, people often ask if it's because of my mom. She was diagnosed when I was about 12 or 13. So it definitely planted a seed, but a big part of it was the hope that I found in MS clinic as I was doing my neurology training compared to the other clinics that you have in neurology, such as the Parkinson's clinic, the Alzheimer's clinic. So these medications, it feels different. I'll tell you, there's a lot of hope. And then being here today, I have renewed hope also for what the next 10, 20 years are going to bring in our field. I spend half my time taking care of patients living with MS, and the other half, I focus on training other neurologists to be MS specialists and also on my research, which is focused on developing new diagnostic tools for MS. Part of erasing MS is coming up with a cure, which we're all working hard towards. But once we have a cure, how do we know who to give it to, right? How do we know exactly who has MS? And so what I did back in my training, and I was lucky enough to train at both UCLA and Cedars, wonderful MS clinics, is look at how many people with an established diagnosis of MS don't actually have it. And the numbers were remarkable. It's up to 1 in 5 patients. And these are people who had been living with MS for anywhere between 6 months and 20 years. The majority of them were on disease-modifying therapies for MS, but they had something else, and they'd been mislabeled as having multiple sclerosis. And it's a shocking number, but if you ask a lot of MS specialists, they'll say, yeah, this is probably about what I see in my experience too. So it translated across both clinics and here in LA, and I think it translates even wider than that in other studies that have been done since then. So that's the problem that we're up against. What is the solution? So part of what we're doing is developing new tools to more accurately diagnose MS. And as you heard from Dr. Calabrese, there are new diagnostic criteria coming up, which will hopefully do a better job than the criteria we use now. Because the reality is any person with MS will tell you is this is not like taking a pregnancy test and having an answer in 5 minutes. I wish it was. That's my dream, is to have a blood or urine test that we can do in a few minutes that gives us a super accurate answer. But it's actually a list, a checklist that every doctor has to go down and see whether that patient in front of them meets these criteria or not. And these criteria keep changing for the better, but it's hard to keep up with and to understand. And there's a small amount of subjectivity there too, is really literally part of these criteria. We have these amazing MRIs, but the doctor has to look at them and say, well, did these lesions, plaques, spots on this person's MRI look like they were caused by MS or do they not? And yes, we spend years of training in the pattern recognition, but that's literally what it is. It's pattern recognition, which is not an objective yes or no answer. That's kind of the ideal, right? Is we have just a clear machine spits out an answer. So some of the new tools that we're developing to try to get more specific, more objective with the way that we use our MRIs to diagnose MS are the central vein sign, as you heard about very briefly, and paramagnetic rim lesions, or PEARLs, as they're nicely called. So the central vein sign goes back to this thing we've known on pathology almost since MS was described in the 1800s, is that MS lesions don't form randomly. They really like to form around tiny blood vessels in the brain, around tiny veins. And so when you look at an MRI or when you look at a lesion on a slide, for example, under a microscope, you can see the demyelination or the MS lesion. And in the very middle of it, you see a tiny vein or a blood vessel. So what's been developed in the last few years, and Dr. Pascal Satie, who's at Cedars with me, is one of the heads of this investigation. And as you heard about, Race to Erase MS was a big part of starting to investigate this, is he's developed a way, a technology to take different types of MRI slices. If you've ever had an MRI and been in there for way too long, I'm very claustrophobic, so I'm so sympathetic to how horrible an experience this can be. You're in there for a while, right? And that's because they're looking at the brain in a bunch of different ways. So what he's developed is a way of layering a few of these sequences to see not only the MS lesion that we see on a typical MRI, but to also be able to see the blood vessels, these tiny veins in the brain. If you put them together, you can see, do this person's lesions center around a blood vessel, or are they not around the blood vessels? And in MS, you should see most of the lesions center around blood vessels. In the mimics of MS are the things that trick us sometimes into thinking the person has MS, like migraine, for example, or ischemia, vascular disease, as we heard about. Those lesions are away from the blood vessels. So it's pretty simple. You kind of just go through and look at how many lesions they are. Are they centered around the blood vessels? And that could give you an extra tool into understanding whether this is multiple sclerosis or not. And that is called the central vein sign. It is not available right now everywhere. It is available at Cedars. If anyone's a patient at Cedars, this is part of your technical MRI. And I think a lot of our centers have this ability. But my hope is that in the next few years, this will become a widespread technology that most people with MS will have access to that will make the diagnosis more accurate. The other thing that you heard briefly about was paramagnetic rim lesions. And these are dark rims around MS lesions, again, that you can see on a different MRI sequence. And these are specific for MS, meaning even if you have just one of these in your brain, it highly increases the chance that you have MS compared to one of the mimics of MS, because these mimics, people typically have 0 pearls in their brain. Again, it's a new technology, it's being developed now. And then as we develop a new technology, we also have to think about how we're going to make this widely available to everybody who might have a diagnosis of MS or who's living with MS. What we've done is we've taken these tools in small scale studies so far and applied them to groups of people with MS and people who had been in the real world misdiagnosed with MS. So these are people living this reality. They've been told they had MS. Then we'd undiagnose them once they'd come to our center. And what we saw is that with the central vein sign, it could take over 80% of those people who'd been misdiagnosed with MS in the real world and give them a correct diagnosis of not having MS. Right. So it does really, really well when you apply it to a real world population of people who've actually been misdiagnosed. And with the paramagnetic rim lesions, that also did really well at identifying the population. Now, not everybody with MS has pearls. It was only about half the population or our group that did. But the people that did have a pearl, they all had MS. So it was a really nice test for honing in on who actually has the disease. Another tool for now that's diagnosis, we also want to talk about how do we follow the disease over time. So I have bad news for everybody in the audience, those with MS and those without. All of our brains are shrinking as we speak. It's a normal part of aging. With MS, our brains shrink faster than they should for typical aging. And this has been a marker of looking at brain volume and the rate of shrinkage or atrophy in clinical trials in MS. Now, this has been a really tricky technology to implement widely because some of the automated techniques and softwares that have been used for measuring brain volume aren't always accurate. And I'll tell you, when we tried to roll it out at Cedars, I had some panicked calls from patients who got the results before I did and didn't have a chance for me to intercept and explain to them. So there's definitely some work to be done there to improve the accuracy of these techniques, but that's also something that is going to become important as we try to follow the disease over time is what does somebody's brain volume look like? And is it changing faster than we would expect? And is there a chance for us to intervene and treat before that atrophy becomes, continues to go on at this rate? So there's a lot of great new tools. It's a really, really exciting time right now for how we diagnose MS and then also how we follow MS because there's a lot of room for improvement in this area. So look out for that in the next few years to change. Thank you very much.
Thank you, Dr. Casey. And next, Dr. Emmanuel Wabant is going to speak on how we measure MS progression.
Good morning. I am a neurologist at UCSF, and I'm also the medical director for the Race to Raise MS. So I'm herding all these doctors and all these scientists. I've been doing that for 23 years, I think. And it's really wonderful to see the collaborations and the scientific discussion. So part of my role is to organize twice a year a scientific meeting where all these doctors share their progress and discuss and critique their findings. And that is always very inspiring. So yesterday we had a fabulous scientific day before the gala. And one of the most uplifting part of the meeting, actually, that really speaks to what Nancy has done in terms of funding research for MS is funding young investigators at critical stages of their career. So yesterday we were 35 scientists in the room, and then we had 20 more online. And among the 35 scientists in the room, there were actually 10 young investigators that had received funding from the foundation and could speak to how this funding at early stages of becoming independent had really launched them in the world of research very effectively and had set up wonderful career trajectories. So it was very warming to see those young people who are working together, collaborating together, and are becoming leaders in the field. So this new generation was very refreshing to see. So my topic is to talk briefly about how do we measure MS progression. And you've already heard from some of the other colleagues how that can be done with MRI mostly. So I want to focus on what do we do as neurologists when we see patients? How do we know there's progression before we do an MRI? So we ask patients about their symptoms. We ask whether there's an increase in the severity. We ask whether there's new symptoms, trying to understand whether it's related to MS or not, because sometimes it's really difficult to discriminate between what's related to MS or not. But then we also examine you. But I think hearing from patients first is really critical, and especially for people who have progressive forms of the disease. And I always ask my patients, so, how can you walk before having absolutely to rest before to take a break, basically? And I really track that down based on what the patient tells me. But then I walk my patients also in the clinic to follow up on that, because it's one thing to be walking in the streets, crossing streets with cars and bikes and busy pedestrian ways. But when you can walk someone in the clinic with a simple corridor and a measuring stick, then you can really have a more quantifiable way to try to monitor what's happening. So this is from the clinical standpoint. With the MRI, you have heard that we can look at atrophy, for example, so kind of shrinking of the brain that may occur faster than it would happen with aging. But we can also look at whether there are new scars that appear in the MRI, which is a marker of an early marker of a higher risk of relapse or of progression. We have blood tests also that have become available in the recent past. One of them is neurofilament. So serum neurofilament is something that became available commercially, which is measuring a degradation product from nerve cells that we can find in the blood of patients. I see that as something that can be replacing some frequent MRIs, for example, that is cheaper. I don't think that this is something that we need to use on a monthly basis, but this is something you'll hear about, and probably your neurologist can talk to you more about it. And then there's OCT, so the optical coherence tomography that Dr. Calabrese had discussed. We use it not only for diagnosis, but we can use it also for monitoring how the optic nerve is doing over time. So these were the few things I wanted to share with you today. Thank you.
Thank you, Dr. Wabang. And we have one more topic to discuss. And after that, we'll be doing the lightning round to answer the collected questions that we have. So next, we have Dr. Adam Kaplan, and he's going to be talking about mental health.
Great. Thanks so much. I wanted to start by mentioning how much I appreciate Claudia involving me in these. Claudia doesn't believe in disability. She believes in determination and doing. If anybody wants to ask about how you can teach classes in writing and still need a motor scooter, you need to talk to Claudia. It's quite impressive. Nancy, to me, is a human antidepressant. She doesn't believe in stigma. She believes in solutions and saving lives. So the topic I wanted to talk about today is saving lives. And in order to talk about that, I'm going to talk about suicide and how to assess someone who's suicidal. Why this? Well, because we just recently got reports back that 2023 was a record-setting year in a way we don't want to set records. There were over 50,000 Americans who died by suicide. That is the largest number since recording that information. So take home message right now, 988. That is the suicide and crisis lifeline number, not 911, not 311, 988. So that's the take home message. It's been there since 2005. And they'll help get through these. So MS is a breeding ground for depression because attacking the brain, the immune system causes depression. Depression is the breeding ground for hopelessness, and hopelessness is the breeding ground for suicide. 30% of people with MS will have thoughts of suicide. 10% will make an attempt. So it's very relevant to this room as well. So the rates, unfortunately, have been rising. Suicide rates have gone up 36% overall, 62% in our young people, 10 to 24. In fact, suicide is now the second leading cause of death in that age range. And that really just needs to stop. We need to start asking people how they're doing and get them through. So how do you ask people? Well, the first thing is you need to understand that if you ask someone who's having a hard time if they're suicidal, it will not cause them to become suicidal, because no one ever said, gee, that's an interesting idea. Thanks for suggesting it. I think I will now go kill myself. No, in fact, if the person is having suicidal thoughts, they are more distressed than you can imagine. Talking about it helps them. So you can only save lives if you ask people who are in distress. You also have to normalize the thoughts. So I tell people 60% of people with depression have thoughts of wanting to call it quits or, shuffling off this mortal coil, but you stigmatize the action. So normal to have the thoughts, don't do it. Depression is temporary, it's treatable. Death is forever, like herpes in plastic bags. So it is something, it's the wrong solution. The other reason to tell them not to is because any one of our lives is connected to 135 on average other people. And it is a sin in every organized religion to kill yourself because you fit into the fabric of the group of people that you're in, and removing that stitch will unravel for everybody. So how do you then assess how urgent the situation is? There's a series of just 5 questions you need to ask. If you get a no, you stop. If you get a yes, you keep going. And the more yeses you get, the more you need to be concerned and then take action. The first thing is, are you just having thoughts that life's hard, really tough, you'd rather go to sleep and not wake up? Or are you actually having active thoughts of ending your life? If it's the former, that's called a passive death wish. Check in on that person. They're not going to kill themselves if they're just having passive death wish. But if they say, yes, they're suicidal, the next thing you want to know is, do they have a plan? Have they written a note? Have they chosen a time, a place, a method? If they say yes, you want to know, have they procured the means for that method? Yes, doctor, I was having thoughts about killing myself with a gun. I went out and bought a gun recently. Big red flag. At this point, your blood pressure should be going up and you should already be thinking about 988 and how to intervene here. The next question is, have you rehearsed? Have you taken the gun out? Have you, people rehearse things to try to get ready to do them. And so you want to be concerned. And then the final question is, are you right now here in the room with me having those thoughts? If the answer is yes, don't leave the room and go call somebody. Sit on them or take them with you wherever you're going to go to find someone to help. Past behavior is the best predictor of future behavior, so find out if they've ever done this before. There's a genetics to this. Family members who kill themselves have first-degree relatives who have a 2 to 3-fold increased chance of killing themselves. Risk factors, well, it's just a statistical issue, which is elderly white men who are alcoholic and recently lost their jobs, wife left them, and are socially isolated and have a gun are the highest, group. And the more or less of those sort of risk factors you fit into, the more or less concerned you need to be. Gun owners, gun owners are 2.5 times more likely to kill themselves than they are to kill some other attacker or something like that. So guns do kill people. And in fact, if you have a suicide attempt with a gun, 85% success rate. Overdosing with pills and the like is a 3% success rate. So it really does make a difference. There are what are called red flag laws. California is one of those places, also called extreme risk protection order. If someone has a gun and you need to temporarily get it away from them while they are suicide, you can go to the local court. They will issue a judgment. Someone will go to their house, take the gun away temporarily, and ensure their safety. Last thing I just wanted to tell you is that suicide comes at a time of a crisis. If you get someone through that crisis, it's not like, oh, gee, just that's only temporary. The next time something happens, a month from now, they'll kill themselves. In fact, if you look at the Golden Gate Bridge, 1 in 50 people survive those falls, and many people get talked off the Golden Gate Bridge. This is before they had ways of catching people and preventing them from jumping. And in a study where they looked back for decades later, 94% of those people were alive and leading productive lives. Only 6% of those people killed themselves. So if you can intervene, you can save that life. Every time I've intervened, even if it means sending police to someone's house to save their life, my patients have thanked me. And they may not have liked the way I did it, but they understand I did it to save their lives. And being alive is a really nice thing to have and to give to someone. So thanks very much for your time.
Thank you, Dr. Kaplan. And now we're going to start answering some of those questions, and I'm turning it over to Dr. Waban.
So very quick round of questions. So please, doctors, have short answers to those questions. First question for Dr. Calabrese, what remyelination treatments are the doctors working on? What causes demyelination? What can I do about it?
So there have been a number of clinical trials with putative remyelinating agents. One of the ideas is that there are cells in our brain that can turn into myelin-making cells. They are actually quite abundant, about 5% of the cells, and they continue to divide. Doctors have identified ways of enhancing their turning into myelinating cells, and they went to fairly large clinical trials that did not make people better, unfortunately. There were some hints by imaging and electrophysiologic techniques that something was happening. So we've gone back to the drawing board to try to understand why that didn't work out so well. And it turns out that the inflammation in the brain that you've heard about earlier, the glial cells may be inhibiting this. And so I think the real hope for remyelination is to turn off the glial inflammation at the same time as we're promoting these oligodendrocyte precursor cells to turn into myelinating cells. And that kind of strategy, that combination kind of therapy, I think will be something that we're going to use moving forward and hopefully get there with remyelination.
Thank you. So Dr. Weiner, please comment on progress in genetic testing for brain health, particularly as it relates to MS demyelination and evidence or not of ischemic activity. I've also had a genetic test done, in vitro blood test, which was inconclusive.
Sorry, so the question is about genetic testing?
Yeah, progress on genetic testing.
Oh, progress. So we know that there's a genetic component to MS, although it isn't super strong. People in identical twins, only 30% of the other twin has MS. So that means that other things are going on. We don't have very specific genetic tests for MS. We don't usually do it. We might screen people in the family who have symptoms by doing an MRI, but there's no formal genetic testing like we do for breast cancer or we're now doing for Alzheimer's. Does anyone on the panel have any other thing to say about that or no? Yeah.
I mean, the genes identified for MS, many people have them and they don't develop MS. So, having commercial genetic testing is a little tricky for a disease like MS. Okay, so the next question is, Dr. Weiner, in regard to microbiome, could MS be caused by today's diet, the fact that our soils are depleted, our animal products have antibiotics and harmful chemicals?
So the question is, if you take too many antibiotics, can it make your MS worse or cause MS? The answer is no. I also don't think it relates to toxins. However, the microbiome, all the bugs in your intestine, can make you susceptible to MS and can affect your MS. Sadly, we can't tell you what probiotic or what bugs you should try and take. Hopefully, we'll be able to know that. When people ask me what probiotic should I take, I really don't recommend one. They ask about diet. There's good evidence that a Mediterranean diet is helpful. So if people want to do something with their diet, then I would recommend a Mediterranean diet.
So there are several questions revolving around diet and exercise. So Dr. Yadav, yes or no answer. How have studies been conducted or research to show how Pilates can help MS patients?
So the diet and MS is a very popular topic, and I think it's a very relevant topic for our patients. Diet, the studies which have been done thus far.
It was Pilates. Pilates is Pilates.
Pilates,
Sorry,
okay,
it's my
sorry.
French accent.
I thought you were talking about diet. So I think Pilates is a good form of exercise. I mean, I think I really, I'm not sure there's anything special about Pilates as such, but I think the whole mind-body connection, which any of these exercise forms can bring, that includes Pilates or yoga or even Tai Chi, all of them I think can be extremely helpful because it's not only strengthening the muscles, it's also stretching. So I think it's all good. But in particular, Pilates, I'm not sure there's a study which is really supporting that by itself has any unique, features. Is that?
Well, short answers. We have only 5 minutes.
Okay.
So, two questions with very short answer. Is infusion a good way to help MS? Answer, yes, for most patients, but for some patients, it may be not the most appropriate. Other short answer, are there any ways to remove brain lesions? And the answer is no. There's natural healing that occurs, but we cannot go remove the brain lesions. Short answer, Dr. Weiner, why can't the root cause and possible treatment be found for MS?
So we actually do know, so we have treatments. So let's not say that we don't have treatments. There's other diseases like ALS and Alzheimer's or whatever that we don't have very many treatments. So we do have treatments, and we have treatments for relapsing disease. The root cause, we know what the root cause is an abnormal immune system. It's the immune system attacking the brain. That's the cause. And all of our drugs balance this immune system that's causing the disease. So we do know the cause, and we have treatments that we're doing. Now, in terms of what starts it, we probably think that EBV infection early in one's life may trigger MS. It doesn't trigger it in everybody because everybody's infected with EBV virus. But in some people, the EBV virus triggers MS. And a big question, and the other doctors here can comment on it, is should we one day vaccinate everybody against EBV virus, and will MS go away? So that's a big question people are talking about. But we do know the cause. It's the immune system in attacking the brain.
Dr. Casey, short answer, can an older MS patient stop taking Rebif or other disease-modifying therapies without increasing the risk of relapse or debilitating symptoms?
It's an excellent question and one that comes up in the clinic almost every day. And that is the idea of our immune systems change as we age. It's this concept called immunosenescence. They kind of chill out is the way that I explain it to my patients. So they become less aggressive. So it's not great if you're trying to fight an infection or surveil for cancer, which are the other things our immune system does. But if you have an autoimmune disease that causes aggressive inflammatory relapses, it can be a good thing for the immune system to calm down as we age. What that means is that people who are older with MS, and we're talking about over 55, but really 60s, 70s, are less likely to have inflammatory relapses than people who are in their 20s and 30s. And if you think about what our disease modifying therapies do really well, they stop these inflammatory relapses. So the question is, do we need to continue these medications when their role is not as clear in people who are, again, in their 60s, 70s, 80s? There was a trial that tried to answer this question called DISCO MS, published last year. And it's a long and boring statistical answer as to what the result of the trial was, but they looked at people over 55 who had been stable on medications like Rebif for years. No new relapses, new symptoms, new MRI changes. And some of them, they stopped the medication and others continued their medication. They looked at which group did better. And again, I'm sure each panelist will have a different interpretation of the results because it didn't really prove that one was better than the other. But what I take from it is that the group that stopped their medication didn't have a huge increase in their MS activity, and that it probably is safe to stop for a good portion of those patients. The tricky part now is who are those patients where it's really, where we are sure that it's safe to stop, and who might actually be at risk of continued disease activity, and we need further studies to understand that.
Thank you. So there are several questions, but again, super short answer. Otherwise, we have to not answer the questions, some of the question. So Dr. Yadav, any comments about plant food or naturopathic or vitamins that should be considered for MS?
The plant-based diet can be very helpful for MS. We have done studies looking at the low-fat plant-based diet, vegan diet, and it definitely improves fatigue. So that's definitely, I think, a research-based evidence that we have. And supplements, we typically don't recommend supplements except for vitamin D supplementation if people are deficient. The blood level can be should be tested for vitamin D, and we recommend a blood level between 40 to 60 for patients assuming like 30s upper 80s upper limit of normal. And other supplements, should be only done if they are deficient. For example, iron deficiency is very common in women at least. So checking ferritin and making sure if somebody has fatigue, should be taking supplement of iron. But otherwise, we do not recommend any specific supplement. Kind of yes or no answer. Does sugar affect MS, make it worse? Eating sugar probably is not a good idea, definitely. So I think it can, but there's no specific research connecting directly sugar and MS. So quick question here. Someone is asking for biologics for psoriasis and having MS. So I think that you should have your neurologist and your skin doctor talk to each other. There's one category of drugs for MS, fumaric acid, so Vumerity, Tecfidera, Bafiertam, that help for MS, and some of the compounds help also psoriasis, but then talk to both of these doctors. Dr. Voskuil, there is a question about, let me go back here. Okay, is the estrogen estriol or something else? Estrogen patch, question mark.
It's estriol. Estriol is a pill. It's been used in Europe for 40 years and shown to be safe for hot flashes in menopausal women. The dose we used in our double-blind placebo-controlled trial, we have 3 papers published. It was a higher dose. It was based on pregnancy being protective. And it goes back to how does it work? What Dr. Calabrese had said, it binds to oligodendrocytes to make them remyelinate, and a 2-prong, it also binds to these glial cells that are inflammatory. So it reduces inflammation. So it promotes making the myelin, and it prevents that immune cell from blocking that.
So 2 questions are on studies of pediatric MS and recommendations for a child diagnosed with MS. So there are more and more studies in pediatric MS. About 5% of all MS patients have their onset before the age of 18. It looks like pediatric MS and adult MS have similar trajectories.
Pediatric patients tend to have more relapses, so we tend to be, as in adults, very aggressive with starting treatment. And that's it for that. So Dr. So the next one is Dr. Calabrese. How is secondary progressive MS detected from being diagnosed with relapsing remitting?
Right now, it's a clinical diagnosis. It just means that you progressed without relapses, typically for a year. I find it this many years into my practice still very challenging because people progress for different reasons. During the pandemic, people got worse because of deconditioning. So I always take a very optimistic approach and try to identify correctable factors. Are they having any MRI activity? Should we escalate the therapy? Are they deconditioned? Is there a nutritional deficiency? We go through a whole list of things to see if we can turn something around and stop that progression early. But it's right now it's a clinical diagnosis.
Dr. Anesqua, when will there be an MRI study for Hispanic males with progressive MS?
Well, I think.
And
for-
maybe using 70. That question is very specific.
So, well, right
Short
now-
answer.
Yeah, short answer. The Hispanic studies are ongoing, irrespective of sex, both with 3 Tesla and 7 Tesla, definitely USC. We're doing that, but specific to males, I think we will have to start with Dr. Voshkal's studies in males.
Okay, so one question is about research on IVIG with B-cell therapies. And I think, in MS, we don't use IVIG typically because the evidence for an effect is missing. So, and then the other questions on that were diets and risk. Maybe Dr. Calabrese, can you talk about the risk of cancer with MS or B-cell depleting therapies quickly?
So there was a theory that people with MS are less likely to get cancer because your immune system's overactive and it goes around looking for things that are bad or abnormal or foreign, and like a cancer. But some recent studies have suggested that in some situations, people may be at even higher risk. And so we, especially as we get older, and if we're suppressing the immune system, so we're correcting that overactive immune system, now you may sort of unmask a propensity for cancer if it runs in the family or as people get older. So we do always recommend cancer surveillance to our patients on these potent immune therapies, but it's a good idea. Get your mammogram, get your pap smear. If you have something that runs in the family, look for it. It makes sense.
So I will give the last question here for Dr. Voskuil. There's a question specifically for Dr. Weiner and your study, the study you mentioned. So I'll give that to you, and that maybe that patient can come talk to you. So last question, Dr. Voskuil, is there a way to know if decreased cognitive function could be from MS or menopause?
Well, that's a great question. Yes, there is. Each situation, whether it be MS or menopause, have been associated with very specific cognitive issues. So it's not decreased IQ, it's not global anything. It's just very specific domains that they're having a problem with. And they differ to some degree. There's some overlap. There's also some separation between what's affected by MS versus menopause, with, again, some shared, some not. So the way to differentiate it is to go to a neuropsychologist, a PhD, who does formal cognitive testing. At UCLA, we do this all the time. It's up to 4 hours. They write a report and you'll find, oh, I'm doing great on this, 90%, but oh, this is 75. This is and they can map which cognitive domain is a problem. And then can say, oh, are these the domains affected by MS, or are these domains affected by menopause, or both?
Thank you. So this concludes our round of questions. Thank you for attending, and I'll pass the microphone to Claudia.
Thank you very much, doctors. We appreciate your information. And Chad, thank you. And in conclusion, Nancy's going to send us off.
Thank you. I told you I'm not very technical. Thank you all for being here today and all those who are watching virtually. Thank you for attending. I'm always learning so many brand new things every time I'm sitting amongst this esteemed group of doctors. So thank you all for, putting down the traditional barriers that exist in medical research and coming to work together as a team and for the good of what our goal is finding a cure. And I'm just so grateful for everything you're doing, but I want you to find a cure a lot faster. So can you rush it? We're in a race, right? Got to get there. So thank you for what you're doing. And I think there's some new studies coming out of these conversations. So we need to make it all happen. And so grateful for every one of you guys. You all bring something so uniquely different and important to the table. And so happy to have you here too, Chad. You're very inspiring and your story is very, very inspiring. You're such a great talent and it's wonderful.